So let me talk about Ellie. Ellie Bradshaw is an absolute superstar in the world of biofeedback. She has a long and very successful career at St Mark's behind her. She had a sabbatical at the world-renowned Princess Grace Hospital in London and is now back at St Mark's. Fabulous news for St Mark's and all the pouches around the world, where she is bestowing her fabulous knowledge of biofeedback to help pouches and potential pouches to manage and control their symptoms and get better control of their pouch function. So without further ado, because I talk too much, I'm going to hand over to Ellie. It's an absolute pleasure to have you speak tonight, Ellie. Looking forward to your talk.
Thank you very much. And thank you so much for inviting me as always. I must admit, I'm slightly nervous about this talk because although I've been doing it for several years, this is my first talk for you as a pouch nurse. So 6 weeks ago, 6 weeks ago, I joined the pouch team back at St Mark's after my time away. Prior to that, I was a biofeedback nurse. And really, I think I was seeing pouch nurses increasingly, pouch nurses. I was seeing pouch patients increasingly within biofeedback. And I realized that if a job came up, it might be a skill set, that's something that I could bring to the role of the pouch nurse. So when the job came up in the team, I actually went for that job, and I was very, very, very fortunate to get that job back at St Mark's with the outstanding award-winning pouch team. So I've come bringing a different level of expertise to those of the pouch team at the moment, but I come hopefully to discuss and engage thought on some of the functional pouch problems that pouch patients can experience. So what is biofeedback? So my role is what's called a hybrid role or a hybrid therapy, in terms of the fact that a biofeedback nurse is seen as a sort of part nurse, part counsellor, part behavioural therapist, part physiotherapist. It's quite a complex, holistic approach to managing bowel symptoms, and it works for a variety of things. It works for things like refractory constipation, and it works for IBS, and it works for fecal incontinence. It's essentially a form of behavioural management where one would give recommendations and advice to patients and then allow them to try them and then engage with them on the outcome of those recommendations. That's the behavioural aspect. It's very conservative. By that, I mean it's non-surgical. So the least invasive solution tends to be my favoured option. Not that I don't absolutely adore surgeons and surgery. I think they're marvellous. But I do think the more conservative the measures, the better the outcomes can be for the patients. So a cautionary tale. So after my last talk, where I went global, thanks to David, I had a lot of queries and a lot of questions from patients who didn't have a pouch but had seen my talk on YouTube. So what I would say is this presentation is specifically for owners or prospective owners of the ilio pouch anal anastomosis, otherwise known as the J pouch. That's not to say that you can't watch my talks if you particularly want to, but I might not be giving you the correct information that you need. I had a lot of patients who contacted me saying this really resonates with me, and actually I may have been doing a great disservice there by not making it very explicit that this talk is for pouch patients. So if you have a colon or rectum or both, I might not be giving you the correct advice or ideas during this presentation. I want to stimulate thought and discussion on pouch management because obviously I'm very excited about this new job because it's only been 5 weeks or 6 weeks, and I'm starting to throw up a lot of ideas about things and about biofeedback in pouch management and about how I can really apply this skill set to practice and how I can create, pathways and systems and ways of best managing pouch dysfunction, because it is fascinating to me. So it's not a substitute for medical advice. As I said, I'm a pouch novice. I'm a biofeedback expert, but I'm a pouch novice. So I would not be the best person to talk about cuthitis or about pouchitis or about any suspected disease within the pouch. I leave that to the pouch experts. That's Petia, Raleigh, and of course, Sarah. I'm a mere pouch nurse novice. I only did my induction today, which was hilarious. given that it's pretty much the same as it was sort of 20 years ago. Very, very sweet. Absolutely lovely to be back, and it's coming home for me to return to the National Bowel Hospital. I was saying to David earlier that St Mark's made me as a nurse, so to be able to return and hopefully give something back is really a profound experience. So moving on, I know you put me on after John Nichols. John Nichols, probably the most eminent pouch surgeon still in existence, will have talked about this and the surgical advent and how we're now going to 2-stage procedures and even, 1-stage procedures, and things are getting very, very, very exciting from a surgical perspective for pouch patients. The majority of you, I believe, will have a J pouch. I spoke to a chap the other day on the pouch advice line who had a W pouch, which I was very excited about because you don't encounter them very often. I've also spoken to S pouch patients, but as we know, the mainstay now is the J pouch. So why biofeedback in pouches? Well, if you look at the long-term sort of strategies in the NHS, supported self-management is a massive drive towards empowering people with long-term conditions or long-term problems to take control of their treatment. So it's to give them peer support, such as the Red Line Group, which is a real trailblazer, in terms of what it has achieved. But this type of thing, peer support, information, signposting, useful constructive advice and information, pointing to specialist centres, pointing to specialist expertise, is really what patients need to be getting in terms of supported self-management. It involves very much the sort of thing I do, which is kind of like health coaching. It needs to be proactive, it needs to be personalised support, and it needs to be quite intensive. And the idea is that you put in a lot of effort in the beginning with your patients, you give them everything and you allow them to self-manage, you empower them to self-manage and give them the ability to make conscious and informed decisions. Okay, so you might be wondering, well, that's great, Ellie, but what does that actually mean in real terms? So for me, in what I do, the mainstay of what I do is the accurate assessment. So for me, the cornerstone of all my work is and always has been the accurate assessment of the symptoms and of the components that make up the different problems. Bowel routine is very important, gauged on your assessment. So what is the best likely outcome given this patient's bowel routine at the moment, given what's practicable, given what fits in with their lifestyle? Urge resistance, you probably know about this, the holding on, urge resistance, or holding on as it's sometimes called, is a way of stretching the pouch, certainly in the early postoperative period, where once stools have a porridge-like consistency, they're a bit heavier, they're a bit easier to hold on to, you're not just passing water. And urge resistance is things like deferring the urge, and I'm going to talk about a bit more detail about that. Pelvic floor exercises, David loves these. He mentions them every year to me. Pelvic floor exercises and targeted sphincter exercises are a brilliant way of bulking up the supporting muscles around the pouch. So we're not just talking about the anal sphincters, there's 2, internal and external. You're also talking about your accessory muscles, because actually the pelvic floor is an entire strip or complex of interlinking muscles. So even if you have had a problem with your sphincter, including surgical intervention or nerve damage, you can compensate to some extent by building up the accessory muscles or the surrounding muscles in terms of continence. Foodstuffs and fibres, I think this is really interesting because it is so bespoke to the individual and you can give very generic advice, which feels totally counterintuitive. And we'll be talking a bit more about foodstuffs and fibres because I do find that absolutely fascinating. Skincare, I've got some top tips on skincare today with some things which you may or may not have seen, things that I've picked up from the department, which I've noticed the patients are getting benefit from. So I'm just going to have a chat through that. Forgive me if you know all of this. Many of you will know these hints and tips from previous talks, but just in case there's something new that you might pick up that you may find helpful, then please bear with me. Okay, so irrigation, Medina catheter, we're going to be talking about that. The irrigation systems via the DO system, this is a newer thing. It's really come to the forefront in the last couple of years as a way of managing pouch emptying. Pouch emptying can be a massive problem, obviously. It's uncomfortable, it leads to unpredictability. It can lead to leakage and incontinence. And containment. So if you are at risk of incontinence, in my mind, there's two main ways of managing it. One is to flush it out or empty completely, and two is to contain it. Now, historically, containment was, we'll give you a pad. But thankfully, things have moved on, and there are sort of newer treatments coming out in terms of anal plugs. And I know that is not for everybody. I accept your preferences and your individuality with regard to choices, but just to make you aware of what's available, this is very much in line with the empowerment, self-empowerment, and making informed decisions as to what may suit you. So this is an example diary. Now, everybody laughs at this diary, right? This diary I show at every talk, and people think it's hilarious because they think it's so obvious. However, I'm very proud of this spreadsheet. And the reason I'm so proud of it is that it gives me a baseline for the patients that I see. So I can look at what they're eating and drinking, the time at which they're taking medications or supplements, so the time at which I took the Paramide, the time at which I emptied my pouch, and the time at which I had any other problems. Now, I'll tell you why this is really important. And this is for the majority of bowel patients that I see. You can put together links. So you can look at what you've eaten. You can look at the time at which you've taken medications. You can look at the outcome of things that you're trying. So it's a very realistic way, I think, of being able to understand if things are making you better, if they're making you worse, or they're not making any difference at all. So the bowel routine, so we've talked about this, leaning back, sitting up straight, leaning forward, yoga, abdominal massage, getting as empty as possible is very useful. Now, this is the standard sort of anatomical way that we advise to go to the toilet, but with a pouch, it can flop back slightly in the pelvis. So patients sometimes find that if you stand up and sit down again, stand up for 10 seconds and sit down again, actually you get a tilt on the pouch and a lining up of the anus with the pouch itself. So sometimes moving around, abdominal massage can also be extremely helpful for pouches, and you'll find lots of videos of that online for those in continuity. It's the same. You go from the right round to the left. Okay, so urge resistance. So we know that certainly in the post-op period, the pouch will stretch. It's like a balloon. So to start off with, it's fairly small. And you know this because you have extreme frequency, often excessively sore skin, and discomfort. But over a period of time, it will stretch to accommodate more. So to start off with, once the stools weigh a bit more, so if they're not completely liquid, they start to weigh a bit more, they start to have a bit more form, it's never going to be a formed stool. Okay, it's ileostomy output coming out of your bottom. But if you can get up to porridge level, and you're in a safe space within your own comfort boundaries, it's time to put off going. So by that, I mean giving it 5 minutes. I'm just going to finish what I'm doing. I'm just going to complete this. This allows the pouch to stretch, and it also helps with anal tone as well, because your anus and your internal anal sphincter will create that seal more readily over a period of time if it's trained. So can you distract yourself? So this is always a good one. There's a lot of new evidence actually about the cerebral cortex, and when you're engaged on another level, sort of intellectually, quite often you can distract yourself from the urge to go to the toilet. And that applies to everybody, whether or not you're in continuity or you have a pouch. Quite often you can distract yourself. So does the urge go off? So try strategies of distraction. So some people prefer to relax, these relaxation methods, deep breathing, whatever suits you. Or you could just do a Sudoku or the cryptic crossword. Personally, I'd find that more stressful. But whatever works for you, try strategies of distraction when you're in the home environment, when you're in the safe space, even if you're further down the line, even if you're not immediately post-op, think about this. Have a think, because often your ability outweighs your confidence. And certainly I know anybody that's had incontinence is so badly frightened and so burnt from having had incontinence emotionally that they won't risk it. I'm just going to go on empty just in case. But actually, behaviourally, often your ability outweighs your confidence. So it is worth trying within your own safe space to defer the urge when you feel ready. Okay, so David's particularly asked me to put this in. He's quite obsessed with these exercises. So there's an app called Squeezy, which is an NHS app. I don't know whether or not many of you have seen it, but this NHS app will text you to remind you to do your pelvic floor exercises. And David did want to teach this bit himself, but I've said no. So the external anal sphincter muscle is like any other muscle in the body. So are all the pelvic floor muscles. If you exercise them, the tone improves. They get bigger. They get stronger. Their endurance gets better, so you can grip for longer. So although the internal and the external anal sphincter are governed by different mechanisms, so your internal anal sphincter is governed by your subconscious or your deep brain. Your external anal sphincter, you can control voluntarily. However, they overlap, which means that if you have an Olympian strength external anal sphincter and you have a strong pelvic floor, even with the loosest stool, you have longer to get to the toilet. Because if you can squeeze that muscle and your accessory muscles and your overall tone is better, you will have longer to put off going. So just to recap, pelvic floor exercises. So some people do them sort of on the floor, so buttock exercises. I'm quite a simple kind of a girl. Everybody at the Red Line group will tell you this. I just like a really straightforward, bog standard pelvic floor exercise, which I think is brilliant. So all you do is, if you're a bloke, you squeeze your bum hole and pull it up like you're picking up a coin. You hold it for 5 seconds and you relax. Now, don't use your buttocks, boys, because your glutes are not the problem. It's your sphincter. So squeeze your anus, that ring of muscle, and the analogy is you squeeze and you lift up a pound coin. Don't actually do it. That could be embarrassing in A&E, but just imagine that you're doing that. You hold it for 5 seconds, you relax for 5, and you squeeze and lift and you hold for 5 seconds and you relax for 5. It's getting the signaling going as well. So it's not just a matter of improving the tone and the strength, it's also getting the signaling going between the brain and the pelvic floor. Now, if for a woman, you pick up 2 coins, one with the anus and the vagina. Gentlemen, you may also pick up the coin and pull up under the base of the penis. So you're using that big hammock of muscle, hoik it all up, hold it there and relax. And you'll find, using the Squeezy app, which is really, really, really idiot proof, even I can use it, that you can actually increase the amount that you do. So I say about 20 to 25 exercises per day. And then over a period of time, you can increase to holding for longer until you've got a 10 or 20-second endurance. That's really, really useful. So by the time you can squeeze for up to 20 seconds, you'll win a chicken dinner. Because what that means is, if you can hold for that long, you can calm yourself as much as possible, doing whatever it is that takes to calm you, and move to the facilities. So even when you've had an internal anal sphincter, problem, some of them have been cut due to surgery in the surgical process. Some of them have been damaged by things like radiotherapy. Some of them have been damaged by things like childbirth. There is still so much you could do. And I think they really are very underestimated. I think the role of those muscles, the pelvic floor, the accessory and the sphincter muscles, is really underestimated in pouch care, because the pouch is supported by the pelvic floor. So obviously, if your pelvic floor is descending, getting older, getting weaker, the pouch is more likely to be dropping, isn't it? And potentially that means it can, what we call intercept, it can fold, and it can really give you big problems emptying. I'm not saying that the pelvic floor is the perfect solution to everything, but I do think that the value of those exercises should not be underestimated. Okay, so get your Squeezy app, download it. It will send you notifications, at which point you turn it off because it makes you want to throw your phone out the window. But even if you just have it on your phone, it means that when you're doing your usual, who's texted me, and you're on the tube, you can just sit and quietly do them. Don't move your buttocks. You're not exercising your buttocks. You're using all of those muscles underneath. Okay, so foodstuffs and fibres. So I read the diaries that come in, and I find them really, really entertaining, because I just think what people eat and how people eat it is absolutely hilarious. I just think humans are just absolutely fascinating. So obviously, when you go home with your pouch, you're on a low fibre diet. Give the bowel as little to do as possible. You are not going to be eating loads of fibre. Your bowel will not thank you with a new pouch. You're going to be on a low residue, and it feels very counterintuitive to say to somebody, don't eat any fibre, because they're like, well, for my whole life, I've been told to eat more fibre. And now you're giving me the opposite advice. But the thing is, without a colon, you don't need fibre for motility. There are other ways to stay healthy with a pouch that don't involve fibre. If you are going to have it to start with, go for softer fibres. So I'll leave this to the dietitians, because these guys are whizzes at this stuff. But in very broad terms, osmotic fibre, so watery fibre, soups, stews, smoothies, as long as there's not too much in one go, are a good source of fibre, and that can actually help thicken things out. Now, in terms of bowel, psyllium is a really, really good one to use. So that's probably the one with the most evidence. So you can get psyllium capsules, psyllium powder, and that can cause the stool to stick together a bit more. So it can be a thicker sort of porridge consistency. Some people will say, Ellie Bradshaw, you are wrong. Oat bran is the way forward. So it's not a one size fits all sort of thing, but psyllium is most certainly the one with the most evidence for thickening up output. So remember, constipation reported by patients is sometimes evacuatory dysfunction. So quite often patients always have, and probably always will say, but I'm really constipated because I only go a little bit. It's not technically constipation, it's evacuatory dysfunction, or an evacuation problem, in that you're not going in one go. And that's the scenario whereby you pass a small amount of stool, you get up, you wash your hands, and you think, oh God, I've got to go back. That's not constipation, that's an evacuatory dysfunction. And this is due to the fact that you have a completely different anatomy from what you have. So we're not talking, the ileal reservoir is not the same as the rectum. It doesn't have the same nerves. It doesn't have the same absorption capacity. So when I was lying in bed at 2 a.m. last night, thinking about this talk, because I was really, really nervous about it, I was thinking, what you're doing is you're asking ileum to do a completely different job. So it's a bit like saying to me, Ellie, I know you've been a successful nurse for 20 years, but I really think you should go and be an accountant. That's what you need to do. So that's what you're doing with the ileum, isn't it? You're sort of refashioning it and expecting it to do something it's never really done before. And that's why the pouch training takes time. And I think that's why, if I went off into accountancy, I might be amazing. I might be pretty much doing the budget for the government, or I might have a few problems with coming to terms with the fact that that wasn't my job before. And that's where the training comes in. That's where the support comes in. So wind busters, the girls are really good at this. I shouldn't call them the girls, because I clearly know that they're adult women, but Petty Aurelians are the queen of this type of thing. So all those subtle hints and tips that really are game changers. So sabbatical, brilliant wind buster. Peppermint oil capsules, peppermint oil in hot water is another good one. Because you can just add 2 to 3 drops into hot water covertly from your pocket after food. Very good antispasmodic. Buscopan as well, very good antispasmodic, very useful in terms of kind of excess wind, pouch and pelvic floor sort of spasming, certainly in the early post-op period, or latterly if you need it. So probiotics, so it's not really proven that probiotics work, I think. But anecdotally, there's a bit of evidence on VSL3. But before you go spending a lot of money on probiotics, try the less expensive ones first, because anecdotally there is a lot of kind of reported improvements from some of the probiotics. I'm not going to name names. I'm going to let the Red Line group discuss it. But even some of the dietary probiotics patients can find useful. So loperamide, orodispersible, they got rid of the liquid, and I was devastated. So they've stopped manufacturing the liquid, which is really annoying because you could take it in tiny increments. But you can use Oreo dispersible, so melts, you can break them in half, you can break them in quarter, you can carry them with you in your pocket, you can secrete them in the side of your mouth when you're out on a night out, and nobody will know. And the Oreo dispersible tablets are really fantastic because actually they're so quickly absorbed in your mouth that their action is much speedier than taking a tablet or capsule. And I also think that they give you a massive psychological crutch, so Imodium Instant or Oreo dispersible, you can get it from a lot of places now. Don't pay for the name Imodium. You can get Oreo dispersible loperamide from Newmark Pharmacy for about £2.95. So don't pay for Imodium. Codeine phosphate, many of you will have tried codeine phosphate, very good for overnight leakage, because obviously it kind of relaxes you, it settles everything down, it slows gut motility, and it can reduce nocturnal leakage. Codeine phosphate, I always say start at night, just because codeine phosphate can make you feel a bit drunk. And I know this from personal experience because I had a hip injury and I just was clearly very sensitive to codeine, and I just went round loving everyone. I mean, literally, it was, in hindsight, quite embarrassing. But codeine phosphate makes some people feel really drunk. So start it at night just to check that you don't go round hugging people that you don't necessarily know. Cholecalciferol and cholestyramine, had a really great chat with a lady this week. I hope she's watching. We're talking about bile acid malabsorption. Now, bile acid malabsorption is something that will create excessive bile, and it can happen. It doesn't happen to everybody, but it can happen if you've had your gallbladder removed. It can happen even without that. But it means that you get an awful lot of yellow bile, stinging pouch output, and actually it's very easily treated. And you treat it just with what we call a bile acid sequestrant. And what that means is, simple terms, it soaks everything up. It soaks up bile. And you can even take these even if you don't have bile acid malabsorption, because it soaks everything up. So that's another option that I think, and sometimes you can kind of take these things together. I think you start with one. We're talking about the systematic approach, and then you build in. You don't alter too many variables, or you don't know what makes things worse. You don't know what makes things better. Okay, so skincare, I get quite obsessed about this because many, even doctors, right, I have to remind them that the skin goes into the anus. It doesn't go skin bowel, it goes skin. So it's up to 2 to 5 centimeters of skin that you've got on the inside. And quite often it's that skin that burns, that causes itchiness, grittiness. The word I can't say, pruritus at night. So it's that really needs to be coated as well. So don't just layer up barrier cream on the outside. I know it's not the world's most glamorous thing, but get your finger in a tissue, stick it in some cream, Hydromol, Vaseline, whatever you want to use, and just go up and round by the anastomosis, because quite often coating that skin will create a much better barrier. And I forget how profound sore skin is on patients, and then I see them and I just think, oh my God, there's nothing. It's the ultimate insult, isn't it, that you've got a consistent, constant reminder of what you're going through when your skin down there is so sore. So there's a lot of barriers available. I'm not working for anybody, I'm not sponsored by anybody, but I have noticed that this is very good. Medi Honey, have you seen this one? This is a new one. Medi Honey is extremely good. Medi Honey is in a lot of places because we're now looking more towards the natural things, and this is obviously has honey in it. Wipes, be really careful of baby wipes, guys. I've seen a lot of people who've been using baby wipes. Try not to do that because you can have a reaction. Use aqua wipes, they're water. So water, pure water, or blasting yourself, if you can, if it's convenient, with a shower head or a portable bidet. Just using water and patting the area dry is often a lot better than wiping. Post-operatively, we tend to give you stuff like this. These are barrier wipes. These you can't have prescribed, you have to buy them, but they again have a film on them that moisturizes and nourishes the skin. But even just a quick, obviously I'm not suggesting that you do this every time you empty your pouch, but even just a quick blast with a shower head and then just burying up that skin just on the inside can be really, really helpful. Okay, so irrigation, what is it? So there's two types really. So irrigation, you can either drain out, so you can just drain out pouch content using this. This is a Medina catheter. Many of you will have seen these. And it has two holes in it, two eyelets. And it's a tube. And what you do is put lubricant on it, insert it into the pouch, and obviously empty the pouch onto the toilet. And this can be really useful if you have sort of a very narrow join. Obviously, before you start using any of this, it's quite important that a clinician examines you to check that you don't have a surgical stricture. But using this type of thing to empty the pouch can be really useful. I met the most inspiring chap this week who had a thoroughly miserable time of it. He found the Medina, a little bit of water enema, and that's it. He empties 3-4 times a day. Life is a completely different story. And this was a guy that was seriously considering going back to a stoma. So it is worth considering these things if they are acceptable to you. Some people say, no way, I am not doing that. And I'm very respectful of your choices and your preferences and your decisions. But so you can use this to drain, or you can use a syringe. You fill it full of warm water, 60 mils or 100 mils. You stick it in the end. Bit of a fiddle faddle, but you put it in and then you instill the water, hold on to the water for as long as you can, move around, and then release the water and the pouch content onto the toilet. So sometimes if you use this sort of thing, sort of draining out or using an anal douche or using an anal flush before bed, you often find that actually you're less likely to leak, because the emptier you are, the less disruptive your night might be. Can be very successful. There's a range of systems. So just looking at the actual water installation, it's not just the Medina catheter and the syringe, which is all we used to have. Now we have other options. So we've also got the Aquaflush Compact. That's the blue one. I really like that. And the reason that I like that is because in the interest of science, I try all of these things myself, because I am really cack-handed. So I think if I can use something, I can teach someone else how to use it, because I'm just not particularly dexterous or practical. I'm quite clumsy. I really like the Aquaflush Compact because if you look at the shape of it, it's a water enema bulb, but it's got a cone that goes up, so you can sort of squeeze it externally. The Q4 Mini Go is the one there on the right of the screen. That's a lovely bit of kit. It's only a small bit of water, sort of, I think it's about 120 mils, but it's a lovely portable bit. Yeah, of course you can use it more than once, and it's very good for stuff like holidays, because you just tuck it into sort of effectively a toilet bag and off you go. So there are new things, and I'm sure there will continue to be more things coming out all the time. I hear whispers from various companies on new products that will be emerging, and I bet by next year I will be presenting on more of this type of system, if you let me come back. That is, if you don't, then maybe not. But if you let me come back, I will be able to, I'm sure, enlighten you on more advents of things that will help. So containment. So I said to you before, I don't just want to say to somebody, wear a pad. To me, a pad is, they're hot, they're uncomfortable. Many people find them really undignified. I know they're necessary. I'm not, doing down pads or pad wear, but it may be worth looking at one of the newer options. So we've got the Renew. Now, this is really good. We did a small study on this for nighttime leakage. So if you get a little bit of essentially, minor passive mucus leakage, that type of thing, this is really good. So all you do is you just pop it up. You'll see, and it creates a sort of little barrier between pouch content and the outside world. If you have profuse leaking overnight, this won't work, okay, because it's not highly absorbent. This is a new thing, and Gary was pulling faces at me for this, but actually I've tried this and it is not painful. So this is actually the Navina. It's a proper plug. So it's really, 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 really soft. It's quite incredible, actually. So I've tried this and this does not hurt. So you just pop it in, and obviously what it's doing is creating a complete seal. So it's properly plugging you. So actually, if you're going swimming, or you're going out and you want to wear a white pair of jeans, this may well be an option for you. Obviously, you have to experiment, like we were talking, in a safe space, in a way that's appropriate for you. That's the applicator, and you just sort of pop it up. But I was actually really amazed at how easy that was, because I looked at it and went, oh my God, no. But actually, it's very comfortable. So it's always worth exploring these things, having a think. Okay, so my thoughts as a novice pouch nurse / biofeedback specialist, because I'm not going to call I have not earned pouch specialist. I told Luke, our long-suffering administrator, to take the word specialist off after my name, because I think it will be many months and possibly years until I can consider myself a pouch specialist coming from that department, because you know exactly who is in that department and how incredible they are. So my thoughts as a novice pouch nurse, but also a biofeedback specialist, is I think there's an enormous amount of scope for research, and I'd really love to know your thoughts on that. I'd really love to know what you would find helpful in terms of what we should be looking at. So even if it's just, an idea you've had of something that may be helpful, or where you think I could be driving research into pouches and pouch function, just let me know. And this came up a couple of days ago with a patient I was talking to on the phone, and it was really sort of a bit of a light bulb moment, because I do these quality of life scores which the girls set up, which is fantastic. So you're speaking to people, and we've got this enormous database, all of this data, all of this hard work, and you're asking questions, and you're saying, has having a pouch affected your sexual function? Is it, and so many patients last week that I was talking to mentioned this to me. And I thought, why the hell aren't we talking about it more? And whether or not that will end up being a potential area for my research going forward, as you know, St Mark's is very research based, I don't know. But I just wonder, why aren't we talking about it? Because we're talking about sex everywhere else, aren't we? And we're talking about bowels more and more. I mean, there's even adverts, I remember 20 years ago, you'd never seen an advert for an incontinence pad. You'd never have seen an advert for constipation or diarrhea or IBS. Sex is everywhere, basically. Everybody's talking about sex. Aren't we talking about sex and sexual function with pouches? So I think that's one of the things that I'm thinking. I think my mind's turning over ideas for research. So I'd love to know your thoughts. As always, you are my superheroes. I couldn't be more honoured than to be setting off on a journey to be a pouch nurse now with my absolute superheroes. You are an incredible bunch of people. So, okay. So keep it simple. Don't change too many variables all at once. If you're going to have a go at home, not everybody has access to a pouch nurse. Not everybody has a direct access to a clinician they're going to see all the time. So if you want to experiment with these things, keep my spreadsheet, keep a diary, and monitor the effects of everything you do. So if you're going to say, right, actually, I'm going to change my loperamide dosage, or I'm going to change the timing on it. I'm going to try this at a different time. I'm going to try eating slightly differently. You will see patterns in cause and effect of new things that you try. I think, although it's really boring, and I was, oh my God, I don't want to keep a diary. Certainly in the early days when you're going 20 times, no. But when things have settled, it is worth keeping a diary. It is worth trying to draw your own conclusions from interventions to see what's helping. I always think of myself, I'm a bit like the optician. I look at the diaries and I'm like, what about this? Was it better, worse, or the same? So ask yourself the same questions. Is it better, worse, or the same? What really is helping you? But just don't alter too many variables. Do it one thing at a time for at least 3 days, at least 72 hours with pouches. You've got to try something for 72 hours, absolute bare minimum. And then remember that multimodal treatments work best. So it's unlikely that you'll have the perfect pouch function. You might do. I hope you do. But quite often you find that the best possible effects come from a variety of measures and getting the timings right. I've been quite astonished actually by changing timings on things. So I had a patient who was very much like me on codeine, total liability, couldn't trust him to go out if he'd had a codeine. So I said, well, why don't you just try cocodamol at night? So that's what he did, which is 8 milligrams codeine, and that was it. Nocturnal leakage went away. So you've got to slightly think outside the box with these things. Okay, thank you so much for listening, everybody. So I want to say thank you for inviting me, as always. You have me back every year, and you're always so gracious and lovely. Now we're going to go RLG. I was going to say confidential. Now Gary is going to be recording the Q&A, but he's going to be keeping you completely anonymous within that, so we can maintain confidentiality, and I hope we can have some openness and discussion. If you don't want to ask questions or put them within this forum, then 100% you can contact me directly, and I'll make my contact details available to you. Okay, thank you so much.
Absolutely brilliant. Thank you so much. Thank you so much. An absolute fabulous talk. Really good. Really enjoyed it. Great tips. Really great tips. I was thinking whilst you're talking, a couple of things. The first is, I think, having gone through what we've gone through, there is a temptation, I think, to think that surgical solutions are the best solutions. The surgeons have saved our lives. They've transformed our quality of life with pouches, and we're very grateful to them. But a lot of the chronic problems and challenges that pouches have post-surgery, I think, can be addressed by non-surgical means. And it's really a real pleasure to hear you advocating that in what you're saying. And
I do firmly believe that many, and I said this at the interview at St. Mark's, I believe that many of these pouch function problems can be better managed. And I'm not anti-surgery. Surgery has saved your lives. It has saved your lives. Yeah. So I am not anti-surgery, but I do think when it comes to doing things like redoing joins and, potentially very risky operations, unless it's necessary, if there's a risk of cancer disease, in which case it's a no-brainer. But I do think you have to make sure you've exhausted the conservative management options. That's my feeling of it, is before you go anywhere near a pelvis, unless it's an emergency, make sure you've tried everything else. That's my thought on it.
Yeah, absolutely. Right, let me ask some questions. And just a last comment from me is about sexual problems. I think in all the time that I've been sort of seeing issues and posts on the J-Pouch Facebook group, and when we used to have the information days, I think I've only heard one person ask a question about sexual problems.
Why?
One person, that was a young lad who was contemplating surgery, and we all sort of looked at the floor and looked at the ceiling. There was someone doing some sexual outcome research, a research reg at St. Mark's. I'll pass on her name if you like.
Find out who that was, because I kind of feel like that's sort of something you could get your teeth into for, for publication and for coming up with pathways and to engage clinicians in knowing what questions to ask and what advice to give.
Yeah.
That could be really valuable.
Yeah, I'll pass it on. All right, questions. All right, we have, in no particular order, all right? So I'm going to fire them. Any dietary advice for thinning stool in a kinky pouch or avoiding thickening other than laxatives?
Have you tried psyllium to try and get it to negotiate? That's quite a specific. It depends where the kink is. That's what I'd say. So is it the?
That's me. I was going to call you Carrie then. Sorry, it's the sex talk. It's
Claire. It's you.
Yes. It's me.
My little inspiration. Darling, how are you?
I'm okay. I asked the question on thinning.
Run that by me again, because
Yeah.
So lots of information on thickening. I don't take anything at all that would be in any danger of thickening, because I've got a very kinky pouch, and my issues, particularly at the moment, are emptying. I'm really, really struggling with emptying. And so I have migraine, for example, and I try not to take any codeine, because the next day I'll be suffering. I can't take any loperamide, anything that will thicken things. Or slow motility seems to, I feel like, I know you said, I know it's not proper constipation, but I get really stuck.
Oh, it feels like it. I'm not saying it doesn't, that isn't exactly what it feels like, but technically
happens when
I'm down. Yeah.
But when I'm stuck, I get massive cramps that start right at the bottom, and it feels like somebody's trying to impale me with a broom handle. And you have to hold on really tight so as not to lose control. But if you do lose control, nothing's coming out anyway. So it's proper stuck. So I'm thinking about keeping it thinner.
Have you tried? Okay, so keeping it as thin as possible. Have you tried natural things like prune juice, slippery elm, this type of thing, the lubricant appearance that are very, very natural?
No, I've got Laxido, so I tend to take it as a treatment rather than, because I can go a week or more sometimes without that being stuck. But when it sets in, it can be a few days. So that's
I see. So you don't take it prophylactically, you take it when you're in extremis.
Yeah, like I've taken 2 sachets of Laxido 3 hours ago now, and nothing's happening. So I don't want to take up the time going to my personal.
No. That is a bit too quick for Laxido to work with a pouch. I can give you some advice more on natural things that I think will think. Quite often things like a bit of prune juice, and it's a bit disgusting, but something that's soluble fibre and has an osmotic effect, a bit like Laxido does, can be really helpful. Let us talk again. We're due to talk anyway, so we'll talk in more detail about that. But that's an excellent question. So thank you for joining us. But we'll talk later in the week.
Let's move on, if that's all right. There's a few questions to get through. We've got a question all the way from New York City.
Oh,
New York
New
City,
York not be in bed? Why is New York not in bed?
So psyllium and peppermint oil, how much to take and how frequently?
So you know what I'm going to say, don't you? You're going to have to keep a spreadsheet. So I would say I'd start with something like 1 psyllium scoop or capsule at night. The idea being that it can sort of form things overnight, provided you don't leak overnight. If you leak overnight, have frequency overnight, take it in the morning and then monitor the effect, taking 1 peppermint oil in hot water, 2 to 3 drops in hot water. You can take after every meal.
Okay. Thank you.
Pleasure.
Great stuff. Thank you. I'm just looking for another.
Oh, hang on, Darren. Somebody's saying that there's actually a current into pouchy sexual function. This person needs to come and talk to me.
Yeah, I'm going to send you the details. I'll find that and I'll send it to you. Thanks very much for that nudge. So back to the top. Just bear with me. So quite a specific question, but actually one I've seen before on the forum. Any ideas as to why I have anus and lower back pain, especially if I've been sitting all day at my desk? The only way to relieve the pain is to lie down completely flat. This person's had a pouch since 1997, so it's not a new pouch.
And has the pain been there for all that time?
Don't know.
You don't know. So anal spasm and certainly posterior compartment spasm can often be due to nerves and muscles. So yeah, I think when it comes to, and I see pelvic floor spasm and anal spasm, even anovaginal spasm in women relates to quite often your new anatomy, but also the nerve involvement that happens with lower pelvic surgery. So you can end up with, sort of trapped nerves and jangling nerves and very peculiar nerve sensation, and that nerve sensation will cause the muscles to spasm. But there's quite a few treatments for that as well. So it would depend if it's muscles, does heat take it away? That's tends to be a good sign that it's muscles. So if heat gets rid of it, applying heat gets rid of it, hot sitz bath, hot water bottle applied to the area when you're lying down, lower back, that tends to be muscles. If heat doesn't relieve it, that's more indicative of the fact it's a nerve problem. And if it's a nerve problem, I would say try nortriptyline. So nortriptyline is a neuromodulator. It's a tricyclic antidepressant, but that's not why we use it. We don't think you're depressed. We use it to suppress nerve signals. So it cuts down on the signals between the brain and the pelvic floor and the brain and the lower guts in particular. So something like nortriptyline, 10 milligrams at night, may well take the edge off that if it's nerve pain. But any low pelvic surgery has the additional risk of disrupting nerve responses or muscle responses.
And nortriptyline is presumably prescription, isn't it?
Yeah, you'd have to go and have a chat with your doctor, but it's quite commonly used in a lot of sort of pain, nerve pain and muscle pain syndromes. So they're used to prescribing it, and it's very, very, the reason I prefer it, so amitriptyline's okay, but it's quite sedating, whereas nortriptyline isn't as sedating. So it's probably the single best thing for that type of discomfort where you can't sit down.
Brilliant. Thank you. Here's one right down your street. I've been referred for biofeedback at St Mark's, which I'm waiting for. I've used a Medina catheter multiple times a day for 6 years, but I sometimes have pain and soreness from using it. I can't empty at all without it. How can biofeedback help me, please?
Well, firstly, using lidocaine gel. So you need to use lidocaine gel for numbing, but actually biofeedback can help you in terms of an examination would probably give you a bit more, and that's what the biofeedback team do, would be able to give you a bit more advice on your anatomy, and they may even offer you a slightly different thing. So like one of these, a combination of anal douching or anal irrigation plus Medina, and you might find that you don't have to use the catheter so much if you have a combination of irrigation and Medina. So I do think biofeedback, these nurses are also extremely well placed to advise you on emptying. So I think you're going to the right place.
Yeah, so the lidocaine is a local anaesthetic, isn't it? So
yeah, before we put catheters into you chaps, you have like a syringe of numbing gel, and actually that is really effective. So numbing gel is really effective. So any lidocaine, you can buy it online. It's called Instilla gel. So I'd absolutely make sure you're using Instilla gel, because you need that, and apply it prior to the catheter insertion. Give it 2 to 3 minutes to sink in and take the edge off the pain. That can be very, very effective.
I know that one of our regulars on the pouch forums uses a bit of tape around the holes in
do you know what? It's the design, it's the eyelets.
Yeah, the eyelets, and it can be a bit sharp, and so he wraps some tape round and I think cuts holes in it. I'm not quite sure the detail.
That's really clever, because I was thinking about saying to them, can you do one without the holes in? Because that is often the bit that catches, isn't it?
Yeah, be careful putting it in.
Got to be really careful putting it in. Yeah, but obviously a numbing lubricant is likely to make you less tense as well, because one of the problems is if you're already sore, you're going to tense. So actually a numbing lubricant could be a good thing to try.
But you put the lubricant on and give it a couple of minutes to work?
I would just coat all of this, including filling this up, and then I would get it up and round on the inside as much as possible, give it a couple of minutes, then have a go, because you're more likely to be relaxed.
Yeah. A quick comment here. Hi all, think I'm the gallbladder lady Ellie referred to in your talk. And just an update from the gallbladder lady, 2 weeks post-op, no pouch issues, and with advice, pouch best it's been, and with advice, the pouch is the best it's been in quite a while. 5 full nights sleep. So that's a really good feedback. So there you go. Making an impact.
Was that my advice that did that?
Yeah, I think it was you referred to someone you'd seen with a gallbladder problem. Anyway.
I'm firing on all cylinders.
There's also quite a few comments in here about sex, with people volunteering to help out with any kind of research or Q&A that you want to do.
you.
Quite a popular topic, I think, and something which we really don't get many questions about and much topic. So I
But
think,
why don't you get the
yeah,
question? Is
yeah.
it because people don't want to ask or they aren't being asked by their clinicians? That's what fascinates me. It might be that there's literally no problems, but I have a feeling that there are problems. We're just not asking the right questions, and patients might feel shy about discussing it. But
I'm
once
sure.
I've got hold of this research person, that's it.
Yeah, yeah. Well, the
I'm going to be
incidence,
recruiting.
the incidence is very low. It's sort of 1 to 2% in that pouch survey, 2017, but I suspect it might be a little bit higher. Anyway, let's get back to the questions. Hi, Ellie. I've had my pouch for 2 years and have been diagnosed with Crohn's. I get pain after my third meal, so I've switched to having a smoothie protein shake for dinner. Do you think my pouch bowel can't cope with 3 meals per day? My gastro thinks that. And can I build up to 3 meals again? Difficult one.
That's a
Very
difficult one.
difficult.
It's one of those things where I'd like to be actually looking at you to see what your weight is.
Yeah.
I mean, what you could do is, I mean, obviously you're hungry, aren't you? That's why you need a smoothie and a protein shake. But could you perhaps sip that throughout the day and shift the time of your meals so that you're taking in fluid, but you don't, but you're breaking it up a bit. So I would say protein shake, be a bit careful, just check it hasn't got too much aspartame or artificial sugar in, because that can make you feel a bit bloated and a bit rubbish, and that will upset your pouch. But I would say I would look at the timings of your meals, and I would see whether or not you can fast in the latter part of the sip something like a protein shake, a very natural one, throughout the latter part of the day. But alter the timings of your meals and see whether or not you can balance your nutritional need and not feel hungry, but without sending your pouch into a frenzy of overaction.
Very good. We have got a talk. We've got a Q&A session on July the 29th, I think it is, with Gabriella Pufu, who is a dietitian
Gabby.
at St Mark's,
Now,
and
Gabby is the queen of dietetics.
yeah, and she's given a couple of talks. They're on the web, but she's doing a double act with Uchu Mead, who's the
Pharmacy
at St
How
Mark's.
lovely.
The goal which we're wanting to achieve there is to explore these sort of nutrition, nutraceuticals and pharmaceuticals.
That's brilliant.
I think there's a big grey area there in terms of pouches looking for solutions to some common problems.
That's because there's no research.
Yeah, and some things are available prescription only, some things are available
And only in certain areas.
And some of the claims for some of the the non-prescription stuff can be quite compelling, but not necessarily
good for you. I know, that's why I say don't rinse too much money on anything till you've tried it.
So we tried it. Right, here we go. Back to the questions. My 74-year-old husband has a 20-year-old S pouch. A recent pouchoscopy showed no inflammation and he was dilated from 15 to 22. I don't know what that means, but I guess millimeters. Symptoms were leakage a little during the day and occasionally massive leaks at night. He also has small bowel slow motility. He keeps a bowel motion and food diary and has 5 to 9 bowel motions per day. His pattern seems to be several small bowel movements followed by large movements. Wow, this is an essay. It seems to me that his pouch hangs on to stool and he is not completely emptying. Would regular enemas help and/or pelvic floor exercises?
Yes. No, with the S pouch, because of their configuration, I again believe that they do kink and drop. So I would say that water enemas would be a very good idea because you could probably get more out in one go. And also pelvic floor exercises, it's always worth making the most of it. So when you've got a stricture and it needs dilating or stretching out, that doesn't mean that the muscles are perfect. So if he's had leakage, it's always worth doing the exercises to support the pouch from the underneath. So he's pushing, when he's bearing down, he's pushing his pouch against his own musculature. So the short answer is yes. I think irrigation would be really, really helpful for him. And I also think that pelvic floor and sphincter exercises would also be helpful.
Excellent. Another one. Would the Renew product be okay to use if I have multiple fistula situated just below the pouch?
Do you know, the company would say no, but I would say you could try. That's what I would say. Because even if it goes inside, it's very, very inert, so it's not going to sort of cause other fistulas or anything like that. It can't erode, it's not solid. So the company would say it's contraindicated, but I would say have a go and see if it makes a difference. But also consider other things like water irrigation.
Yeah, right.
With a very, very thin nozzle. But that's yeah, I would say if you can get hold of some, it is worth a try, because even if they get inside, they're not going to cause worse problems with fistulas. They're too soft.
Okay, brilliant. We're jumping around a bit here, but here's one on well, I think this is about physics. Can the pouch interfere with urination? This is from a gentleman. Can the pouch interfere with urination by pressing on the bladder and or prostate while in bed?
So technically the nerves are all interconnected, which means that if you don't empty your pouch properly, you might not empty your bladder properly. So there is an interplay. Can the pouch flop onto the bladder? Not in the male pelvis, no. Everything's too far apart generally. But what I would say is, depending on your age, you need your prostate checked.
Right. I have read comments about people when they first have their pouch connected and they go to urinate, and it feels really odd, like there's big pressure changes going on in the pelvis.
Well, you've had like somebody's hands in your guts, haven't you? Or like his little. So your gut clearly being asked to do a completely different job and then being handled is slightly raging. So
Yeah.
that the nerves responses tend to get very, very jangled. So you can get numbness, you can get pain, you can get very peculiar nerve sensations post-operatively. That's quite normal.
Right. Very good. A comment here from a regular about using melanin dressing.
Melolin dressing, that's excellent. I hadn't
For
heard.
butt burn. Yeah.
Oh, for butt burn. So just to apply, just to wear
Yeah.
the dressing
Yeah.
to stop any chafing, leakage. That's excellent. I'll
Mm.
make a note of that for my records. Thank you. That's excellent.
And Hagar dilators. Is there a
Yes.
place in this world for Hagar dilators?
Yes, but only under medical direction. So if you have had a diagnosed stricture and have been advised that it is safe to dilate, then yes, there is a place for Hagar's, and it's literally just a metal implement. You put it in, you turn it to keep the anastomosis or the scar area open. So there is a place for it, but that's not the sort of thing I expect you to be experimenting with on your own. You need to do that under the advice of a clinician who has examined you.
Yeah.
You need to know the size.
Yeah. Absolutely. I think we're coming nearly to the end of the questions.
Oh, you're really, really giving me an easy time.
I'll tell you what.
Is this because I'm new?
I'd say the people are being so kind as well. They're being really complimentary. It's not like the normal crowd. That's a joke. That's a joke, everyone. So
What did they do to John Nichols? What did they do to John?
Oh, they were just fawning. Yeah, I mean, there's a lot of love in the room for John.
Well, I think there's always a lot of love in the room for John. Let's be honest.
Yeah, let's be honest.
Let's be honest.
Here's a question. What was the name of the bigger plug, please?
Oh, the bigger plug is called the Navina. So that's Navina, and it's called an insert. And the reference number for prescription from your GP, which I hope will happen, is 69304. So this is the smaller one, but I was really impressed with this because when I saw it, I thought, oh no. But actually, very impressive. Very impressive.
And presumably, actually, I was thinking this. Very practical. Let's be frank. Let's be blunt. if you wear a butt plug overnight, do you
Mhm.
have to be prepared for a bit of a flood the next morning when
No,
you take the thing out? I mean, presumably your
you'd be on the
pouch
loo, darling, wouldn't you? You'd
yeah.
remove it on the loo and then sling it into the wastebasket.
But I asked that question because I've never tried any of those things, but as you're removing it, obviously you've got to relax
Yeah.
in order to remove it.
Oh, you haven't, because
And
no, it's really springy. So it's kind of like it's mobile. So you don't have to relax. It's not hard.
oh, I see. I was thinking that your hands are going to be in the way once
No,
you.
because there's bits on the outside, so you just pull it. It's like it would be like a Tampax.
Oh, okay.
No, it's really, really soft. This
Is
is why I keep talking about it, because I'm very excited.
Mm.
the
So
other
you
one,
literally pull it out on the loo and then, you know.
because there are cotton ones, aren't they? But you're pulling out. Are they like tampon type ones as
Well,
well?
there was a sponge one and they stopped manufacturing it, and I was devastated because I thought that was just the best thing, certainly for nocturnal leakage, if it happens in a profuse amount. But there are all sorts of things on eBay.
Okay, and the Navina ones that you get that from, how do we get those?
Well, if you speak very, very, very kindly to your favourite pouch nurse, she might stick a couple in an envelope for you tomorrow.
Oh, I will give you, sorry, her,
Give her an email.
thank you.
All right.
Can we aggressively address
Aggressively?
a pet hate of mine, which is straining on the toilet,
Training.
straining. Is
Training.
straining good for you or bad for you?
Well, there is a way of now, if you'd have been watching my talks for the last 15 years, you would know the answer to this, David. I'm actually feeling slightly disappointed in you. There is a
Found
way
out.
of I know, there is a way of increasing intra-abdominal pressure without straining. So what you can do, now it's positional. So you might find that if you lean back on the loo, or you lean forward, or whatever suits, is that actually if you push out your lower tummy as if you're pretending that you're really fat like Santa. So if you push out your lower tummy and keeping your tummy pushed down at the same time, not too hard, David. You don't want to
I'm all right, I'm cool. Yeah.
and then relax. So you make yourself fat, you push down and you relax. You make yourself fat, you push down. So what that creates within the pouch is intra-abdominal pressure, which means that the anus will open. So fat, push down, relax. I've got a leaflet on it somewhere. David will give you my contact details. It's called the brace exercise. So it's for non-pouch patients, but actually the same thing applies. You create a certain amount of pressure through the pelvis to create movement within the pouch, and then it forces the anal sphincter to open. So it's the same whether or not you have a rectum or a pouch, creating appropriate intra-abdominal pressure. Straining is when you sit for protracted periods, pushing from your shoulders, getting cross, releasing adrenaline and cortisol, getting more and more angry in an effort to empty. That's what causes potentially hemorrhoids, potentially fissures, breaks or splits in the skin, which is really common if you have a pouch anyway, because you're certainly with frequency. But that's what is, less helpful, I would say, with pouches, because lateral thinking makes you think, I need to be as empty as possible. I'm going to go and strain. And that's normal to have those thoughts, but actually it's counterproductive, because all that happens is the longer you sit there, the crosser you get, the less relaxed you are, the less likely you are to be able to empty. So using the brace exercise, fat, push down, relax, and getting your breathing lined up with that is really, really much more helpful for you. And then getting up, moving around, abdominal massage, sitting down, fat, push down, relax.
Yeah. And I mean, when people don't empty before bed, they're inviting, not fully emptying, they're inviting nighttime bowel motions, aren't they?
Inviting is a bit harsh, David. I
Well,
don't think we're
no,
saying,
no.
I'm
All right,
inviting you to disrupt my
You're
sleep.
right. It's totally inappropriate. But
It's
if,
so
all
inappropriate
right,
that I feel I should report you.
let me go back and revise that. If you're able to fully empty by, sitting on the toilet for as long as it takes, by using a Medina catheter if you want to, or other emptying devices, so that you go to bed with a completely empty pouch.
You're
Yeah.
less likely to need to get up. It doesn't mean that you're sorted. You're
No,
less
no,
likely.
absolutely.
You're less likely to leak, and you're less likely to have several trips to the loo overnight. But there's no guarantees. But
No.
more complete emptying at night laterally, logically, means that you're less likely to have disrupted sleep and less likely to leak. Yeah, you're absolutely spot on. I just like teasing you mercilessly because
No, indeed. Yeah, I know.
I only get to do it once a
I'm
year.
used to it. Yeah, I'm used to it. Alrighty, so I think that is a brilliant. Oh, here we go. Best sore bum cream ever to be made in the world. Other bum creams are available. Has been discontinued abruptly. That's Ilex.
I rang Ilex.
Did
So
you?
I rang Ilex and the number went dead, and I am on a mission. I am
Right.
on a mission to find out something with similar properties, because this is not the first time. Bear in mind, I've only been there 5 weeks. This is not the first time I've heard this about Ilex, that this game-changing cream has stopped. So I phoned them. I was like, I'm not going to give up until I've found you. So I'm going to find out what the active ingredients is, and then I'm going to find out if there's something similar. So I will let you know via the Red Lion group if I find out something that has the same sort of properties.
So
don't give up. We'll try to locate something similar.
okay, I mean it's still on the website, Ilex. So
no, it's not there. Honestly, it's been discontinued.
Oh, right. Okay, that's maybe something we can work on.
Can you start hounding them? Because I phoned them about 10 times and it just went dead.
Yeah, if we'll take that on. We'll see if we can get any answers and stick
Could you, David?
stick
Because
on the
as you
website.
know, I am a bit busy. So if you
Yeah.
could do that, that would be great.
I think calmospertine, that was another.
Oh yes, that's
Yeah.
a very good one. I've heard about that.
Okay, ladies and gentlemen, it is now 10 to 9. I think
I haven't had my dinner yet.
I think we
Only
should
for you.
draw this to a close. One more.
Go on then.
Is there a link between having a pouch and interstitial cystitis in women?
I would say yes. And there's 2 reasons for that. One is what I was alluding to earlier. If you don't empty properly from the back, you may not empty properly from the front. That can lead to static urine in the bladder, which can cause the low-grade inflammatory process, which is associated with interstitial cystitis. Furthermore, you're more at risk of contamination, not due to anything you're doing, because your stool is so loose, you're more likely to have cross-contamination between your anus and your urethra. So yeah, I'd say you are definitely more prone for those 2 reasons.
Brilliant. Well, not brilliant, but
it's not brilliant, David. You've obviously had cystitis.
No. And there are questions coming in, but we're going to need to draw this to a close. So
I haven't had my dinner.
If my apologies if we don't get your question. There are some really nice comments, so I'm going to read a couple out here. I'm so glad, Ellie, that you take seriously and address the psychological aspects of pouch life. Thank you so much. Brilliant and entertaining as ever. Please keep on doing what you're doing. We couldn't do without you.
Oh.
And perhaps one last one, if I can find it quickly, was talk amongst yourselves. Ellie, you are a total joy to listen to. Thank you for such an inspiring talk.
Was that my mum?
Thank you for such an inspiring talk. It's great to know what biofeedback actually is. Love your idea for research into sexual function of the pouch, and a number of people have said that.
That's great, but I need to liaise with whoever's doing it, and maybe we can come up with something together. That would be fantastic.
So how are we going to do this, Gail? I can write up the session. We've got the recording, but in terms of contact details for Ellie,
use the pouch.
Oh, the pouch. Yeah.
The pouch advice, because I am getting through it.
Okay, wow. That'll be a busy. So That's the phone message, or email.
No, just email, because I'm
Just
not
email.
secret emails.
Okay.
Yeah,
Okay.
the internal pouch thing. I am working my way through them slowly,
Well
but
done. Well, best of luck with that. Goodness me. Listen, thank you so much. On behalf of everybody here, the recording will be available on a YouTube channel in a day or two, once Gary gets the editing done. But on behalf of everybody who's attended, and on behalf of Pouches Everywhere, who you're already obviously making a big impact for, thank you so much for tonight's talk, and thank you so much for all you're doing. It's absolutely wonderful.
oh, thank you.
Wish you all the best in your new role.
Thank you so much, David. As always, a pleasure. All right. Take care, guys. Thanks for listening.
care.
Thanks for tuning in.
Thank you. Thank you so much.
Yes,
Thank
Ellie, good
you.
to see you. Take
Thank
care.
you.
Thanks,
Thanks, Ellie.
Thank you. Oh.
Thank you.